But our first panel this morning is artificial intelligence in healthcare. And I'd like to introduce our moderator, who's going to take the stage solo to give us sort of a level set. You know, as I mentioned before, as we talk about AI, it's one of those things that if I were to go around this room and ask you, what is AI? What is artificial intelligence? I guarantee you I'm going to hear a lot of different answers of what that means. So we thought it would be a great opportunity for some grounding, and we're fortunate to have Dr. Neinstein, who's the Chief Medical Officer with Notable, here this morning. So obviously, if you want to read more about Dr. Neinstein, that information is in your app, but if I can have Aaron join us, please.
Thanks. All right, good morning. Great to see you all. Hope everyone's caffeinated. I've got one or two in me. So I imagine a lot, we've got a room full of hospital executives. We've been hearing from people all over the country. My board is emailing me and asking me, what am I doing about AI? So how many of you are getting articles sent to you by board members saying, what's your AI strategy? What are you going to do about AI, right? This is happening all the time for hospital executives across the country. And you're wondering, is this a fad? Is this a hype cycle? Is now the time to pay attention? Or is this going to pass? So I believe that the moment for AI in healthcare is now. And we'll spend the next 10 or 15 minutes kind of sharing with you why I believe that. So over the past 30, 40 years, we know that there's been a growth in the number of physicians that we have across the country. But that's been dramatically overshadowed by the growth in administrative burden and administrative costs. It's no surprise why this has happened. We see complexity, fragmentation, more paperwork. I'm still a practicing endocrinologist. I can't walk down the hallway in my office without getting a prior auth handed to me to go sign. And so everything that we do requires more documentation, more paperwork, more people to handle every healthcare service. And we're usually proud to be number one in the US, and we know there are some statistics in healthcare where we're not proud to be number one. This is one of them. Our administrative costs far exceed our peer countries. Now, in most industries, as they digitize, they see productivity increase, prices come down, efficiency increases. Not so in healthcare. So we've gone from near zero deployment of electronic health records 15, 20 years ago to nearly ubiquitous. And we haven't been able to drive up efficiency and productivity in our healthcare systems. And unfortunately, it's not just productivity and efficiency, but it's the experience. So this is a drawing from a girl. This was published in JAMA about 10, 15 years ago now, depicting her visit to her pediatrician's office. And there she is sitting on the exam room table, happy with her parents. And there's the physician sitting at the computer, his back turned to the family, typing away on the keyboard. So one reason that I believe we're in a different moment is that I've actually been able to experience this firsthand in my endocrinology practice. So I take care of a lot of people with type 1 diabetes. And something that's common for people with type 1 diabetes to have is a continuous glucose monitor. We're in San Diego, Dexcom's down here, that's monitoring their blood sugar around the clock, and an insulin pump that's delivering insulin subcutaneously. Now, in the early years of my practice, we would download data from those devices. And I would sit down, every visit would be 30, 40 pages of printouts, where I'd be pouring through, looking for patterns, looking for what changes needed to be made in the patient's insulin regimen based on those patterns that I was looking for. Well, about 7 years ago, the first automated insulin delivery system came out, and I thought I was finished. Why would people need me anymore if the algorithm was going to decide how much insulin to deliver? I was shocked, delighted, surprised by what I found out as these systems came out and my patients were wearing them in practice. Rather than having to pretend to be a computer, and rather than me staring at pages and pages of data, I actually got to talk to my patients. I got to look them in the eye and ask them, what is life like for you with type 1 diabetes? What are your challenges? What are your goals? And so it has completely transformed my practice in endocrinology, and I think Eric Topol really got this right when he said that we don't need AI to cure cancer. We just need AI to help restore the relationship and the trust and the connection between care teams, between doctors and patients. So what are the different categories of AI? So we like to think about this in 3 buckets. Of course, there's different frameworks, but I want to share one with you, which is AI for cognition, for vision, and for language. So first, AI for cognition. So what does this include? This is things like algorithms that can predict billing codes, read through a chart, and help predict codes to support your teams. This is things like personalizing patient outreach. Rather than every patient getting the same message, helping predict what type of message, what words will be most effective for which patients, so that we're not sending everyone the exact same thing. This is automating prior authorization. This is predicting cohorts of patients who are likely to be readmitted to the hospital. The second category is AI for vision. So of course, there's lots here in pathology, in radiology, opportunities to take those images and support providers and care teams in those workflows. But this also includes more basic things like reading information from an insurance card and helping determine the payer plan matching and eligibility so you can reduce denials. This includes things like how many of you are still paying an army of people to read faxed referral documents and type them in to the EHR? So this is computer vision to read information off faxes and enter it into the electronic health record. Now, Dr. Longhurst has shared this statistic with me from UCSD. We've typically heard that about 80% of information in EHRs is unstructured data. Chris ran their EHR at UCSD and found that it was 99%. And so when you think about AI for language, we think about the promise of electronic health records was that we would have all of this digital data, and yet the data is unusable because it's in free text. And so as we move to a world where we've got AI capabilities for language, this unlocks the data and the capabilities that you have in your EHR. This allows things like translating to a patient's preferred language, like finding HCC codes in your chart so that you don't have to have CDI teams or doctors hunting down those HCC codes. It's chart review to support chart prep for doctors before they come in for their visit. So we can start, as we think about how to deploy AI in your organization, we can start by taking a lesson from baseball. So baseball had a problem. Defensive players always stand, I used to play second base, used to stand always more or less in the same position. And the problem was trying to position yourself in the right place to have the best chance of fielding a batted ball, right? And so they created algorithms to predict where each batter would most likely hit the ball. And then they moved the infielders into those positions for each batter. So what did they do? They identified a business problem. They asked a clear question. Is there a more precise location that the infielder could stand to be likely to field the ball? And then they used AI to help answer that question and solve that business problem. Now contrast that to what we've done in healthcare in a lot of places over the last 10 years. How many of you have tried the sepsis prediction algorithm? So every researcher ran out trying to build an algorithm to predict sepsis. And then hospitals all tried to deploy these algorithms to drive clinical decision support. What happened when we did this? Nothing. Because we were asking the wrong question. The question was not, can we predict sepsis? It's backwards. The question should have been oriented around the outcome that we wanted to see, around the future state workflow. So in which patients would earlier antibiotics make a difference? In which patients would earlier ICU transfer make a difference? And so deploying AI into the real world is not about having the best researchers, the best data scientists to go build algorithms. Actually, McKinsey studied this across industries and found that the greatest predictor of success for an organization as they develop and deploy AI is actually being strong in design thinking, in workflow design, in process improvement. And so this means that you don't need to go looking for use cases. You just need to know what business problems you have, what workflows you're trying to impact, and to have teams that understand how to design workflows to be different tomorrow than they were today. So business problems like prior authorizations that are piling up on your teams, like those fax referral documents that everyone is paying armies of people to type into the EHR. And so as we've deployed AI to thousands of sites across the US, we've learned some lessons that I want to impart to you all from organizations that have succeeded in deploying AI. And so the first one, I think, is good news to many hospital leaders. And it reinforces what we were just talking about, which is that you actually need to be great operationally, and you don't necessarily need data scientists. So CIO at North Kansas City Hospital, she said, we're just solving problems that the health system has. None of our staff are asking how it's getting done. They don't care that there's AI under the covers. They just care that their business problem and their need is getting solved. And she said, we don't have the wherewithal to hire a team of data scientists. We just needed to know what our business problems were, and we need to be able to deploy new workflows at scale as an organization. The second lesson learned, my friend Atul Butte coined this term recently that I've grown fond of called scalable privilege. So if you look across the healthcare system today, there's not enough people to deliver the level of care that your organizations aspire to. If you're a low-resource clinic and you want to make sure that every patient is getting their mammograms, getting their A1Cs checked, getting colonoscopies done, it means that you're trying to scrub through your charts to look to see who's had it done and who hasn't. Most clinics can't afford to pay people to scrub through all of these free text notes to find that information. From the patient perspective, if they're working multiple jobs, maybe they don't speak English as their first language, they're not going to have the luxury to stay on hold on a phone call for 30 minutes during business hours, which is when we're staffing the phone lines. And so can we scale information to bring it to patients in a way that's more convenient for them, at a time that's convenient for them, so that they can access care information and services? So love this concept of scalable privilege. And the third thing is that it's a scary time. There's a lot of risk and a lot of concerns around potential harms with AI. And so I love this quote, "Don't compare me to the almighty, just compare me to the alternative." We know our health systems are not able to deliver on our aspirations on all the goals that we have. And so if AI can help move the needle a little bit more in the right direction, it's an opportunity to just try. Start small and just try and move the ball forward a little bit further. So as we've worked with health systems across the country and helped them with their AI strategies, this is sort of the categories as we think about a strategic framework. So when you get that call from your board member, you get that email saying, what's your strategic framework for AI? These are the general categories that things fall into. So again, super important to have a clear business strategy and understand what business problems you're trying to solve. And you don't need to go looking, you don't need to go looking for things that AI can do. You just need to know what problems you have. As I mentioned before, design thinking, process mapping, workflow improvement, process improvement is super important capability in your organization. Change management, communications, change adoption also becomes critically important. And of course, educating your staff. And I think the other thing to start thinking ahead about here is what your workforce is going to look like as time goes on with AI. How are you going to shift people's job descriptions as the capabilities that you have in your organization change? Another important framework that I think is really useful, I often see this tussle between people who are looking at what AI's capabilities are going to be 10 years into the future, and people who are trying to solve the business problems of today. And I think we get caught. I've seen organizations get caught in this debate of, is it one or the other? And the truth is it's both. So this is another framework from McKinsey, 3 horizons. If you think about an automotive company like Ford or GM, they're still investing in the mature business of today, right? They're building better hybrid cars. They're putting Apple CarPlay features into today's cars. They're also investing and focusing in their rapidly growing electric car business. And then they're investing in self-driving, autonomous transport for tomorrow. And so we can structure, as healthcare organizations, we can structure our investments and our planning into these 3 horizons as well. And so some might ask the question, how can we afford the risks posed by AI? And I want to pose a different question, which is how can we afford to maintain the status quo? We know that today's default care model is unsustainable for the country. It costs too much. It's out of reach for too many people. And we're not delivering on the quality and the care experience that we all aspire to. And so I come back to this concept of scalable privilege. And so how can we make care more accessible and democratize access for those who need it? And using AI as an opportunity to help us do that. Because there's a gap, right? There's a gap between the care that our providers and our care teams want to give and the care that patients actually receive. And that space is full of barriers. It's full of faxes, it's full of phone calls, it's full of prior auths, it's full of paperwork, it's full of bureaucracy. And so before I call up our panelists, I'm very excited to have them join me here on stage. I want you to all imagine what could be possible in your organizations in the future when we can use AI to help reduce and remove this administrative burden. So what will your people be able to achieve when they don't have to process every prior auth form as I'm walking down the hallway in my office? When they don't need to be the ones to abstract every chart, and they can think about managing populations of patients with the information that's there in your charts at their fingertips. When they don't need to schedule every appointment manually. We can be in a place where we can help our care teams feel empowered in the work they're doing and help our patients feel deeply known and cared for by our health systems. So with that, I am going to invite our panelists to join me up on stage here. Very excited to have a conversation with you all. We've got Dr. Chris Longhurst, who is Chief Medical Officer and Chief Digital Officer at UC San Diego Health. We've got John McManus, who is Chief Data and Software Development Officer at Sharp Healthcare. Albert Oriol, CIO at Rady Children's. And Shane Thielman, who is CIO at Scripps Health. Welcome to the stage.
Aaron, Neinstein, great job.
Hold on. All right.
Story top is so pretty.
So we have very excited about this panel. We've got such a broad set of expertise and backgrounds here. I'll start by going down the line here and asking you about business strategy. So, what's the case for why, as you think about AI in your organizations? How do you think about the business strategy as you're helping your organizations prepare for AI as it's coming?
Yeah, I think actually, Aaron, your opening remarks, I think, really reflect an important principle, which is while this is relatively new technology that we're introducing into the environment, it doesn't change the way in which you approach successful technology adoption. I think it starts with really a first principles approach, which is what's the problem that we're trying to solve as we incorporate and integrate the technology into our clinical workflows, our business processes. I think, secondarily is this is as much about the technology itself as it is about change management and human factors. And there's an educational component, I think, that ultimately is attributed or correlated directly to the success in terms of the embrace and ultimately the benefits realization that comes through some of these tools. I think as well, there's a level of incrementalism. We talk about transformation, we talk about the revolutionary capabilities that will be unlocked with AI. The reality is that I would imagine it's safe to say that each of our health systems have been using AI for quite some time. What's different, I think, today than even a year ago is that there's been a democratization of access, particularly as it relates to large language models and generative AI. So the chat GPTs of the world, the Bards, the Dollies, these terms that you're hearing about, the general public has access. And I think what that's done is it's really unlocked a level of, I think, creativity and ingenuity that we're finding not just in healthcare, but across all industries. And so I think those are just an important starting point when we think about business strategy. We're going to see incremental improvement over time. And then I think the last piece is where do we go to find those opportunities? Well, we go to where we deliver care, I think, first and foremost. This has to be clinician-led. But we also know that there's great opportunity in our back office processes, and you alluded to some of that in your opening remarks. Our revenue cycle, our administrative processes are laden with waste. And so where can we apply these advanced capabilities and really demonstrate improvement in productivity and operational efficiency, while on the other side of the house, we're actually reducing clinical workload burden, and we're actually providing tool sets and information and insights at the point of care that are moving the needle.
Yeah, thank you. Albert, business strategy for your organization.
Yeah, I don't know that I have a lot to add between your opening remarks and I think Shane's comments. That I think adds pretty much where we are with this. The one thing I would add is, different organizations have different levels of risk tolerance. And so what I think is important is to make sure that you are really pairing your business cases and the initiatives that you are pursuing within acceptable risk tolerance for your organization, and you build the right governance to make sure that you don't get ahead of yourself.
Thank you. John?
Yeah, Shane said it really well. Your opening presentation was excellent. Same from Albert. I would just add there's quite a bit of foundation building. And again, a lot of this gets to what do you need to do before the capability excitement is really there. So how do you have the right infrastructure for choice? How do you put yourself in a position to buy when it makes sense, to build when it makes sense, to partner when it makes sense? I also think that we've spent a lot of time at Sharp really zeroing in on what does it mean to have this North Star? What are these goals? So if we say we're going to reduce the clinician administrative burden or the employee administrative burden, how do we measure that? Are we willing to put that goal into an annual scorecard as an organizational commitment? What are the guiding principles we have around AI? So something that we've talked a lot about at Sharp is on the topic of ethics, but also the topic of human in the loop. And why is that important? And how do you really codify that into something that's tangible, meaningful, and you develop the policies around how you would start to engage and train the workforce. And then finally, really trying to lean into the concept of literacy. So we started with data literacy at Sharp Healthcare, but that now becomes something more akin to AI literacy and really focusing that as a discipline of learning within the organization.
Thank you. Chris?
Yeah, thanks again, Aaron. I really want to compliment you on that opening. That was fantastic. And one of the concepts you touched on from our mutual friend and colleague, Dr. Bude, of scalable privilege, I think is really key here, because we have the opportunity to democratize, as Shane suggested, tools that will make lives better for our patients and for our clinicians. And so I'll pick up on something that Shane mentioned, which is, we've been deploying machine learning tools for 5-6 years now. We have an AI committee for our health system that was stood up 4.5-5 years ago. And it's composed of health equity leaders, risk, legal, compliance, ethicists, and that's really fundamental to our strategy. So for example, when we went to roll out the first in the nation kind of tool to help physicians answer patient questions in our health record, we ensured that we were transparent with our patients. And so every single message that goes out that was automatically generated by a transformer includes a disclaimer that says this message was automatically generated and reviewed and edited by Dr. So-and-so. And we've gotten a lot of positive feedback about that, but that's not core in the vendor tool. That's something we decided to do. And so to Albert's point, I think every organization has different perspectives, risk tolerance, and that's something that's been really important to us, is not only the human in the loop, but also full transparency with our patients and our team members.
And are there, you were talking a little bit about your in-basket replies. Any initial uses in the last couple of years with AI that you're already far down the road on? Anything that you've got just over the horizon that you're most excited about?
Yeah, sure. Well, first of all, the messaging pilot, of course, was prompted by a study we published in April looking at 200 different patient questions and responses. And the headline that came out, unfortunately, said the AI chatbot was higher quality, more empathetic than doctors. And that wasn't really our intention.
They didn't mean than you, just than the other doctors.
Well, it was easy clickbait, but what I really took from that study was that in a short period of time, our doctors, write 3 to 5 sentences, or a dot template, right? And the chatbot could produce 5 paragraphs. So I was a co-author on that study, and as I was reviewing 70 or so of those questions, I remember coming across one. And the question from the patient was, "Doctor, I'm thinking about quitting marijuana. I feel like it's time to stop smoking." And the doctor says, "That's a good idea. Marijuana could be harmful for your health. Let me know how I can help you." The chatbot wrote 5 paragraphs with well-cited research of, here are all the things that have been demonstrated to, shorten your lifespan and But what really got me is it said, you live in California, and in California, there's a marijuana quitters helpline. And I was like, shit, is that true or is that a hallucination? So I called up our addiction pain specialist, and I said, do you know about this marijuana quitters helpline? He says, of course, I run our addiction medicine program. He says, but nobody else knows about it. And that to me was really the point, was here's the opportunity for the chatbot to help surface high quality information that then the clinicians can edit. So we've got some data that we've collected, and we'll be sharing more soon once it's peer-reviewed and published. But they're very exciting results, and obviously it has the potential to help both our patients and our clinicians.
That's a powerful example. Anything over the horizon in terms of your next deployment after the inbox replies?
Sure. We're involved with a dozen different pilots, both with vendor partners and, of course, as a university with our researchers. I was really struck by your sepsis example. Obviously, Michigan had published a few years ago that the EHR integrated sepsis alerts worked not very well, and that got a lot of attention. One of our theses was that EHR data alone was necessary but not sufficient. And so Dr. Shamim Namadi, Gabe Wardy, our chair of our sepsis committee, have been collaborating on an effort to do sepsis prediction exactly like she described. Which patients will benefit, and how do we notify, not because the clinician ordered lactate, which means the clinician's already thought about sepsis, but earlier in the process. And what we discovered was integrating the bedside monitoring data with the EHR data has been very successful. And in fact, we also have some data in press there showing survival benefits. So only the second study, I think, in the country to show that after the large Kaiser study.
Fascinating. John, what do you have deployed today? What are you looking to deploy next?
Yeah, so maybe similar to Chris, going back a few years, 2 things that we're several years into. First, we have an enterprise-wide deployment of a product called Rapid AI. This happens to be a FDA-approved component or algorithm of AI. But we actually run this AI through CT scans of every stroke patient at Sharps hospitals. So that's 30,000 patients a year. And it helps us identify cerebral blood loss to more dramatically recover that blood flow so that we can improve outcomes and recovery for our patients. That's something that's at significant scale, and I think it's been a really good template for us to really think about the protocols, the procedures, the design, the end user adoption, the standard of care element of where I think AI is going to be going in the future. A second thing that we do quite a bit is we have a lot of AI in our security apparatus. So we don't always think about when you're using email within a health system, you have to try and identify PHI or other sensitive components that we want to try and block from able to be released. So we have some relatively sophisticated dynamic AI really evaluating those classifications. But as we look forward from more large-scale proven examples that we're several years into, I think we've really tried to settle in on some key trusted partners and some internal development to really set us up to be successful. So similar to our fellow Epic organizations, and Sharp's about to be a live Epic organization, we're doing the in-basket message reply. We're working on helping physicians create templates using the AI more quickly to help with their charting. We're also working on chart summarization in partnership with Epic so that we can have quick summaries in the chart that say this is what's happened to the patient in the last 24 hours, or this is what's happened since the last time a particular outpatient provider saw that patient in clinic. But separate from that, we have deployed our own internal AI leveraging Microsoft's OpenAI endpoint. And so we've built our own internal version of ChatGPT, but we've really added a lot of customizations that I think make it more appropriate for use in an enterprise health system. I'll just give you 2 or 3 examples. We've used it to help develop a capability to automatically generate meeting minutes, which we're looking forward to try to roll out in our organization in the months ahead. When you think about something simple like that, if it takes an administrative assistant an hour to do meeting minutes from scratch for every meeting, you can leverage AI to get that number down to 15 minutes of really massaging the AI output. That is significant time savings, and it's not even the administrative assistant. Think about your director of quality. Think about the people who are saddled with that burden day in, day out, and what that type of capability could mean for freeing up efficiency. We also are using that product to offer different types of support that I think the commercial AI products really don't offer. So what happens if you have a question? What if you need support? So we've been focused on standing up a discipline of AI concierge. And I think that was really important in your opening comments. You don't want to always be going after technologists. Something we felt was really important is we're going to have to start training technology professionals to really focus on supporting AI in an agnostic way with a white glove, Sharp experience support. So we've been focused on getting this AI concierge discipline off the ground. And then the last thing that I'll point out is we've added in what's known as an adversarial net framework behind our AI, which means we actually have multiple AIs working. So if you ask a question to our AI and it generates an answer, we actually have that answer then get run against a second AI engine and then a tertiary third, so that we're actually trying to fact check, was that answer factually correct, to really work to eradicate the concept of hallucinations, so that when we think about an enterprise use of AI in a health system, we're really focused on a fact, logic-based approach, different from some of the creativity concerns you see in the commercial space. So a real mix of like partner and build that we have going on internally.
That's wonderful. And in case you were wondering, I do not think that we're going to have AI summarize this panel, so you do have to listen and pay attention. You're not going to get automated summaries afterwards, unless John has something up his sleeve.
Nothing's recording that I'm aware of.
I consent.
I am curious, because you have sort of democratized, not completely to your whole organization, but to many, this OpenAI endpoint. What are you seeing float to the surface? How are people still just kind of playing around and treating it as a toy, or are you seeing some really serious needs kind of bubble up as people are using it?
No, we're seeing some very serious needs, but I think the thing that's really bubbled up is and this was brought up earlier, really the concept of enterprise risk preparedness, and then establishing some of the hard work. What is your terms of use for AI? What is your expectations of AI responsibility, your code of ethics within your workforce? How are you training people for AI literacy and basics of prompt engineering to be successful? What if they get stuck? What is the responsibility that they take on when they take responsibility of an AI-generated draft that then they inherit as if it were their own content that they're committing to official records? A lot of the policy development and risk control development, I think, has been a surprising amount of work for me. But it's where I think this really starts to become, are you an organization who treats this responsibly and ethically? Or are you an organization that takes undue risk and will reap the consequences of that in the regulatory space?
Yeah, I mean, I think that's a really powerful insight that getting started means you have a head start on sort of fleshing out all of those needs and capabilities you're going to have to be building in your organization. Yeah. Albert, curious, current use cases, what's next over the horizon?
Yeah, I'll hit that, but before that, I just want to know who checks on the AI, who checks on the AI?
Yeah, it's a fair question. You know, and I think some of that gets back to sampling. We also develop pipelines for our legal and compliance for investigations, and I think a lot of that gets into how are you going to manage the data and the utilization of AI within your organization, whether it's through vendor partners or internal. You're going to have some level of policy controls that involve people spot checking, evaluating, looking for use cases that are against your code of ethics or responsibility. So I think at some point, you can only have so many AIs do their own work, and you start to have to employ the people side of an AI workforce. And this gets back to job description changes and different responsibilities that will come with the technology to properly deploy.
Awesome. Thank you. So now I'll answer. So probably I think Shane made this comment. We've all been using AI for a long time. I can think of computer-assisted coding to help us get through ICD-10 when that came in 2014. And whatnot, probably the thing that I'm most proud of is our phenotyping, which our Genomics Institute has been using since 2016 to help us eventually come up with a diagnosis for our rapid genomic sequencing. But you know, we use it all over the place. We use it on the front end, on the clinical side, to help our physicians in the cath lab to get to a quicker spotting of where there is an issue, to the back end. And we obviously use it for pre-auths. We use it to predict denials. We use it, one very interesting case, we use it to schedule interviews in our recruiting efforts, which always takes a long time and causes us to lose candidates because coordinating schedules is so hard. We use it predictively on the clinical side in our cardiac ICU, incorporating data from our EHR, but also from our physiologic monitoring, et cetera. So I think not so different from everybody else. We're looking at use cases where we have a challenge we're trying to solve, and we have a champion who is willing to go take that next step, right? We found that one of the things that is key for this is to be frontline led, right? This is not IT pushing technology down people's throats, but rather this is the operation side of the house, identifying a problem and saying, we need help, will technology help?
Yeah, it is really interesting hearing both of your comments about, you know, it's not just the clinical and it's not just the administrative and operational in the clinical space, but also these just like internal operations and business challenges like the meeting notes and interview scheduling, lots of opportunities to create efficiencies there. Shane, how about you? Any current favorite use cases or thing you're most excited about over the horizon?
Yeah, you know, I think in your opening comments, you shared, I think, a very well-known, I think it was New England Journal of Medicine article with the diagram, the drawing of the patient's perspective of the physician and their attention to the computer and not the patient. And so several years ago, we identified an opportunity to work with a partner for the implementation of ambient listening. So how can we remove the keyboard from being a barrier in the patient-provider interaction? And I think this was to a degree forward-looking for our organization to the extent that the technology was still being developed. And we have been successful in rolling out that ambient listening solution to about 50 physicians in our organization, spanning a variety of different specialties in our ambulatory environment, and really demonstrating some impressive results, particularly as it relates to one, and I think very importantly, perception of the patient as it relates to how they rate their experience and their satisfaction. I think two, obviously the experience of the physician. I think we are all attracted to medicine for different reasons depending on the role that we're in, but very clearly physicians are attracted to medicine to deliver care and help improve the lives of those that they touch. And while there's been so much promise associated to the digitization of information, structured and unstructured, it's also a barrier today, and it's impactful, and it's actually leading to, as I think you alluded to in your comments, Aaron, there are physicians that are leaving the practice of medicine because of some of the administrative burden that comes with their role. And so what we've seen is we've seen measurable improvement in terms of time and notes. We've seen reduction in pajama time, which we know is a problem for our physicians today because we have the data that supports the fact that physicians are working after hours. And in certain instances, to an extreme. And so we're a learning organization, and we've taken time to also learn where this doesn't work. And what's the composition, what are the attributes of a physician in their practice, in their workflow, in the way that they think, and the way that they approach their documentation that will allow the technology to be successful. Now, what I'll share as well is that while this listening device is predominantly automated today, there is a human backstop. And so today there's a quality assurance function that before that note comes back to the physician for review and sign off, there's a human in the background that's providing that review. But I think as we can all expect, this is already in alpha beta testing to be fully automated. And so we see that this foundation that we've built with about 50 physicians in our organization, we can expand to hundreds of physicians moving forward, removing that human backstop, generating that note almost in real time within 5 to 10 seconds of that exam concluding, and whether that's an in-person exam or a virtual exam. And then I think an extension of that in terms of futures is, can and will that capability be in place to start generating next steps in terms of care actions, teeing up orders, and really prompting our physician in this case to be able to take the next steps. And so that's sort of building on a couple of years of experience that we've had. I think the one other area that we haven't touched on that I think is, and I imagine my colleagues will agree, nursing. So I think we spent a lot of time talking about physician, and I think understandably so, but I think there's great promise in terms of how we can use some of the summarization capabilities that you've heard mentioned in some of the earlier comments and apply those as well to how we think about nursing workflow, communication amongst nurses, communication amongst the care team. Our nurses are burdened as well with an enormous amount of documentation, and the tools and the capabilities are surfacing today, I think, that provide a lot of excitement and a lot of hope for being able to apply those same capabilities in a very meaningful way and demonstrate being able to give back time for other value-added activities.
Yeah. So the ambient listening, Shane, for people who are considering it, is it a run straight towards it? Physicians and patients are loving it, so-so, or not ready for prime time?
Well, I'll speak for our organization. We will be running towards it and picking up pace, I think particularly as the technology continues to mature, and there's a less dependence on that quality assurance human backstop. And there's evidence that the technology is mature such that, I think taking significant next steps forward given the foundation that we've built. And I think that is increasingly more will be realized as a standard of care moving forward, and an expectation particularly of our physicians that are coming out of their training experience that this is really a sort of table stakes for future practice.
So Albert, you touched on something that I think is always a question in healthcare organizations, which is the IT operations relationship as you're bringing new technology in. Can you say more as you're thinking about bringing AI into the organization? What is the right relationship here between operations and IT to do this successfully?
Yeah, for us, it's got to be a very tight partnership, right? And because we're a pediatric organization, over 50% Medi-Cal, our reimbursement is atrocious. So we don't really have the deep pockets to go build big data science teams, et cetera. So we are taking an approach that is more based on partnering with our some key third-party technology partners that support and augment our IT team, and it's almost a bit of a triad, right? It's operations, it's technology, and then it's this vendor augmented team that helps us come with solutions. And so beyond that, I think governance is key. And so trying to figure out where our models, where the kind of vendor generated models are good enough, where are the models, where our data needs to be infused. It's going to be key, and I think Dr. Longhurst talked about all the ethical implications about data, et cetera, and that's something that needs to come into play, right? This can't be just something that we throw at the wall and see if it sticks. We got to be thoughtful about it.
Yeah, and so what advice would you give to operations executives in the room? How should they best work with IT? What's the path towards success at solving a business problem together?
Yeah. So I'm sure you've all had these conversations from some vendor partner out there that tells you they have this awesome solution. Oh, and by the way, it doesn't take IT. It doesn't work like that. So when you hear those things, run away. I think the good vendors know to involve your IT organizations, and that would be my take, right? If you're thinking about a problem you're trying to solve, kind of let your IT teams know. Kind of sooner is better, right? We like to plan. We like to make sure we're not becoming a barrier for you at the 11th hour. That we want to kind of go hand in hand into this problem-solving exercise together.
So John, you were starting to go down this path around as you're opening up AI endpoints. You're realizing there's certain capabilities institutionally that need to be built. Can you dive into a little bit more detail? What guardrails are you creating? What governance are you creating? What can people start to action in their organizations if they have not been experimenting as much as you all have?
Yeah, so I think just building on the last point into your new question, I think it's the goal of any technology discipline in healthcare to really infuse that technology so that operations really just can own it and treat it like breathing, so that IT can focus on just more of the core services like security and stability and infrastructure. with AI being still an emerging capability, I think there's a little bit heavier lead and guiding the organization through the concepts, the disciplines, the opportunities, the risks. But I know at Sharp, our goal is to really infuse that understanding into our operational leaders so that they're able to really kind of carry that forward. Like, for example, we have an AI ethics oversight committee, like I'm sure most of my colleagues do at their organizations. I am so proud that more than half of that committee are nursing and physician leaders. It's chaired by a physician. It's really designed to really put operations in the driver's seat of where and how we guide these technologies and these experiences for our patients or the efficiencies that we're building in. I think the thing that I think everyone needs to really be aware of is the first wave of this concept of generative AI, I think really came forward in the idea of here's a tool, almost like a toy on the side, that you can engage the AI with and then choose to kind of copy paste it into the work that you're doing. I think the next phase that you're going to see a lot more of, and we've shared some examples where we've done this for years, but this is going to be at a much greater scale, is really infusing the AI into workflow as packaged solutions that you're really not seeing the AI operate as the ChatGPT or Bard interface displays to you. So things that we're already starting to talk about is we learned a hard lesson with EHRs for alert fatigue. Well, we're going to have AI fatigue very, very quickly if we're not careful. How are we surfacing insights in a consistent way that the AI is generating so it's not just like pop-ups all over the place? How are we making sure that patients or providers, nurses, clinicians of all kinds, they know that the AI is in use or when it's not in use? How are we building that transparency? And so when we build all that into governance, these are really the topics around standards. How should the AI look? And I know Epic's been very good about this too, really the color coding and where and how it's being displayed, but we're trying to apply that consistently. Something that we did around the data science space before AI is we had some conversations about if a risk score gives a really high number or shows the color red, that should typically mean bad. If the risk score is low and shows a more neutral color like green, that should typically mean good. And so we're trying to do some of the same standards adoption with AI. And you have an opportunity to have all those lessons so that earlier in the program, you don't have to essentially fatigue the organization before you learn better. So I think that there's some of those soft components, and then there's more of the kind of blocking and tackling of AI preparedness and readiness, focusing on your privacy statements, figuring out how you're going to have reportability and controls. How are you going to, like, here's a great example. So our AI deployment, we actually feed all that data into our cloud data warehouse. So we've already prototyped AI transparency reports. Now, we've not rolled these out yet, but our intent is to be able to provide our leaders, so leads, supervisors, managers, directors, based on your supervisory org, who has used AI in a last particular time period, 2 weeks, a month, underneath you, so that you have some visibility to what they're using the AI for, how they're engaging with it, with the goal to be, as you're having one-on-ones, as you're having future coaching, communicating successes or caution around the use of AI becomes part of that management discussion. I'm sure there's the big brother icky stuff we're going to have to manage as an organization, like everybody. But I think it's those type of controls that are really going to make the difference with a real focus on transparency.
And so whose job is all this? So you just described a ton of work. Is this somebody's job? Is this now infused into everyone in IT? Is this the work of the AI Oversight Committee?
Yeah, I'm sure this applies to most organizations, but Sharp in particular, we have an amazing group of leaders that are always willing to adopt new duties as assigned when it's the right thing to do and it's the right discipline to focus on. So we have really diversified.
Who wants new duties on their JD?
Yeah. We've really diversified across operations a set of these responsibilities, and it's really been volunteer-oriented. We've had an amazing response from our leaders about really wanting to be present, wanting to participate. But we also have a number of technology professionals right now, again, guiding the early understandings of an emerging capability, but really finding the right place to land things so that the right portfolios of work essentially gain AI as a part of their overall responsibility for the company. It's not a standalone component, because it's going to be successful if it fuses into operations. If it's a standalone item, I think there's much greater risk.
All right, so Dr. Longhurst, we just heard it's risky to be a standalone item. You just named, or you are naming a Chief Health AI Officer. Tell everyone why you decided to do that as you're thinking about the organizational structure for this. What do you expect that role to do, and why did you create that role?
Well, thank you, Aaron. And first of all, I want to say I agree with all these comments. They're really insightful, smart. The infusion of these algorithms and responsibilities throughout the organization is absolutely critical. One of the things that you point out about our panel, we've got 3 large health systems and a pediatric monopoly here who are, I'm a pediatrician, I get to say that, who are blessed with some resources, and yet it's still hard on thin operational margins to fund this kind of work. It is new work, even though it's incredibly promising. And as bullish as I am, I was quoted nationally as saying that healthcare AI will be as important as the introduction of penicillin. There's still room for a lot of unintended consequences. And so we're incredibly grateful to Joan and Irwin Jacobs, who endowed us with a Center for Digital Health Innovation with a focus on AI to address some of the concerns that John brought up about alert fatigue. We're building out a mission control. And that gift really allows us to do things that we might not otherwise with operational margins. And so next month we'll be announcing our first ever Chief Healthcare AI Officer, who's also the endowed chair of digital health by the Jacobs. And so the combination of the gift and sort of our operational focus allows us to do that. So what will this person be doing? Well, they'll be helping with some of the work that's been described already, and also helping at the policy level. So, I was really privileged to participate in discussion at the White House a week before the executive order was signed. And there's a lot of concern about the potential unintended consequences. There were 5 health systems and 5 payers represented there. And one of the things the White House participants brought up was the potential for doing things like using black box algorithms to create risk profiling, risk scores, red and green, right? Without understanding what's underneath that. In fact, Dr. Neinstein, some of your former colleagues published out of UC San Francisco how this was really exacerbating health inequities when used for scheduling and no-show prediction, right? And so I remember saying at this meeting about a month ago, and the payers were like, no, we would never do that. And then this morning, I'm reading about a lawsuit against a very large payer who was using AI algorithms to help determine approvals. And it's a class action lawsuit. And I think we're going to see more of that. And so there's an important local discussion about how we're using this to optimize our perioperative resources and efficiencies in the back office and coding and other things. And then there's an important state and national conversation as well about how we can drive forward healthcare delivery in a more equitable way in a resource-constrained environment, and do it with an eye towards improving outcomes and equity as opposed to exacerbating what's already underlying.
Are you creating other guardrails, governance within UCSD? What are you setting up in terms of approvals, processes, and governance?
Well, I mentioned that we've had a Health AI committee stood up for about 5 years. It is co-chaired by one of our physician leaders, and it has wide representation on the committee, and that's an important piece of governance, of course.
What does an AI committee do?
So every piece of machine learning, predictive analytics, or AI that's going to go into production is evaluated by that committee for equity, for outcomes, what kind of data set was it trained on, et cetera. And certainly from a legal risk and compliance standpoint, that generates interesting conversations. But I think the other thing that committee does that may get less attention but is equally important is the ongoing monitoring, right? So just like clinical decision support rules, you keep putting in new interventions, and before you know it, your nurses are getting crushed by alerts because nobody's looking at the big picture. We have to do the same thing here. So I'll share a story. When we think about the pandemic, most of us think about March 2020 when the White House declared the executive order. But for us at UC San Diego, it started February 10th when we got that first patient from Wuhan who'd been flown as part of the expatriates to Miramar. And that spun us up on a whole lot of processes and policies, and we had a command center and spent thousands of person hours. And of course, we didn't know at the time whether this was going to be SARS or something bigger. But as a result of that, by the time the White House order came out March 13th, we were actively deploying AI for COVID detection in our imaging, chest x-rays. In fact, of the 600 FDA-approved AI algorithms, about 400 of them are for radiology and imaging purposes, right? And you heard some descriptions here. We've got a bunch of them live as well. So we deployed this, and I remember rounding a few days after it went live, and we were in the emergency department. I asked the ED attending, have you seen any of the color on the x-rays? And she says, yeah, just last night we actually saw a patient brought in from a nursing facility for some concern about possible cardiac issues. We got a chest x-ray. The radiologist didn't see pneumonia, but the AI did, and so we got a test. Now remember, this is March 2020. Like, a test was an act of God at the time, right? And I was like, well, what did the test show? She's like, well, it takes a while to come back. I said, well, let's log in and look. So I'm standing over her shoulder. She logs in, and sure enough, it was positive. And so here we have a patient who had COVID diagnosed far earlier than she would have otherwise. We followed that patient carefully. You can imagine I was very interested. She was ultimately hospitalized with symptoms but never required critical care and was discharged without any kind of bad outcomes. And the perception was, well, this is like really great, right? And in fact, we did a study, and over the course of the summer of 2020, that's what we found out, was that 1 in 5 clinical decisions were being altered by the AI and the chest x-rays. So we published that study, and everyone's like, oh, well, that's amazing. I said, yeah, except for the other piece, which is we turned it off in December of 2020 after we processed 65,000 chest x-rays and CTs. Why did we turn it off? Because the primary clinical utility was helping clinicians decide whether or not to test. And boy, the point, we were doing ubiquitous testing, right? Everybody walked in the emergency department. And so it was no longer value add in the workflow. And in fact, it was potentially quite expensive to continue running that. And so it's a great example of something that was very helpful at the time, but it wasn't helpful long term. And so we have to continue monitoring whether it's a sepsis algorithm or computer-assisted coding or meeting minutes. Is it continuing to add value? Are we looking for unintended consequences? It's easy to think about this as sort of the gateway to turning it on in production, but it's equally important to continue monitoring it in production, particularly if those algorithms aren't static, but they're dynamic and they're continuing to learn from your data.
Yeah, that's really interesting. So it sounds like AI governance is create the rules of the road, create frameworks, approve things to be put into production, and then ongoing monitoring. Shane, we've been hearing different examples of, John has a team that's building things and democratizing build, deploying things that are vendor made. How do you think about build versus buy versus partner, and what advice do you have for people as you think about that? Is it one AI partner per use case? Are you looking for platforms? Are you looking to build? How are you thinking about that ecosystem?
Yeah, I think it's a really important question. I mean, the pace and performance, particularly of generative AI, is, I think the statistic is it's doubling every 3 to 6 months. It's moving at a breakneck pace. And so I think that actually adds some complication to making any significant commitments in terms of a single vendor or a platform solution. I think we tend to be pragmatic in our organization. Prioritization of what are problems that the tools that we have available to us today can solve. How can we work with our existing partners to really understand their roadmaps and and the solutions that they're bringing to bear. And is there alignment? Does the vendor understand the healthcare system's problems and challenges such that they're innovating and they're incorporating some of these advanced technologies into their solutions? I think over time, there may be additional platforms that probably will sit on top of existing platforms like our EHRs and our ERPs, but I think those investments would be such that they would need to be evaluated in terms of benefits above and beyond what we can achieve with some of our foundational solutions that are in place today. I think really importantly, and I think you're hearing this theme, I think feeding back the performance, the outcomes, the process improvements that are being generated through these capabilities, whether they're around clinical care delivery processes and outcomes administratively, they become powerful anecdotes in terms of communicating value and benefit, which I actually think then creates really a program of attraction for the organization to really tap into where I think the greatest amount of ingenuity and creativity is, which is typically where the work is happening, right? Whether that's in care delivery processes or what happens in the revenue cycle. I mean, these are our subject matter experts that know their work inside out. We want them to not be fearful of what is coming, but actually tap into what they see their biggest problems and challenges being, and then be able to sort of partner with them and saddle up together to figure out, okay, how can we integrate and knit these advanced tools into processes and workflow? And then, it is that constant feeding back of results, because I think that creates the sense of progress. And, we are in an opportunity-rich environment in healthcare. There is no doubt, your statistic earlier, in terms of the administrative burdens that are actually driven largely by regulation and billing requirements and care documentation obligations that we have. So I think we have a responsibility, but I think that responsibility is, from my perspective, is to incrementally move towards that transformational state that we think this AI kind of capability can offer a healthcare organization.
Thank you. So I'm going to give everyone 1 or 2 minutes on a last word. Chris, I'll start with you. Where do we go from here? So what inning are we in here with AI, and what do the next few innings look like over the next couple of years?
Well, I like your baseball analogy.
I'm going to stick with baseball
from
today.
the second baseman and go Padres. Right, Dr. Neinstein?
I'm from LA, a Dodgers fan. Sorry, people.
Boo.
I saved that information for the very end.
Well, first of all, Aaron, thanks for coming down and speaking. Really loved your opening. I would say we're in the warm-up. Actually, we're very early in these processes, and the tools hold incredibly exciting promise. You cited one of my favorite statistics, which is when we took out the metadata and the billing data and just looked at our clinical record and electronic health record, literally 99.3% of the record is text data. And so all of the BPAs and reports and everything we've been writing for the last decade is based off of that 0.7% of discrete data. Now that's high value data. You got problem lists and allergies and medications and demographics and other things. But there's so much value in the text data, and the new generative AI tools allow us to unlock that in unprecedented ways. So even when we look at our existing algorithms that were machine learning based off of that discrete data, risk of readmission, risk of mortality, risk of insurance denial, other things, right? Every single algorithm gets more accurate when we add in the text data. Now, why is that? What is the text data bringing that isn't in the discrete data? Well, in large part, it's social determinants, right? Which are poorly captured today in discrete data. So I would say that I'm incredibly bullish overall, but I'm particularly bullish about our opportunities to use this to improve or reduce health inequities. Our partnership with 211 locally to do some digital integration on transportation needs is just the beginning from a pilot standpoint. And I'm optimistic about a bright future. The Boston Globe recently surveyed a bunch of their readers and said, do you have concern about going to a healthcare institution that uses AI? And the answer from the readers, right, just residents, was essentially 90% said, I would have concern if my health organization was not using AI. I think you've heard examples from 4 organizations here in town, and I think we're all going to lift each other up and deliver better care, better outcomes, reduce that after-hours pajama time, and make progress on incredible inefficiencies. My final comment, just agreeing with a prior one, I think we've each been in health technology here for 2 decades or so. So we got 100 years experience on the panel, and between us, we've really hosed a lot of our clinicians. Right? Our electronic health records have done great things for quality measurement, for safety improvements, for efficiencies in other spaces. But what it's brought, as you showed in that JAMA article, to our patient-physician interactions is really unfortunate. And so I think the greatest promise of AI is to restore some of the humanism in medicine.
Thanks, Chris. John, last word. What inning are we in, and where do we go from here?
Oh, it's hard to disagree with anyone on this panel on almost anything that was said. So just in the goal of not being redundant, couldn't agree more with those comments. Maybe I would agree we're in the warm-up. Maybe just focus on 2 things that hadn't been said. I have a submission through the New England Journal of Medicine right now, hopefully it gets accepted, on an AI framework. I think a lot of organizations are missing a compass to really know where you are. And I think it's just one kind of parting word for me is try to find your compass in your organization. How mature are you? You know, simple things like, do you even know what AI is in your organization? How are you bracing yourself for the features that come as upgrades for all your existing vendors, not just the new stuff you go specifically buy for AI? How are you preparing yourself to adjudicate the AI that's about to come from 60 vendors you weren't thinking about? And how do you make sure it's PHI and HIPAA compliant or properly engineered? Find your compass and really try and find that person in your organization who could really help foster and accelerate that so that you find a way of where you are. And then the other thing that hadn't been mentioned too much is expense. AI is expensive. Some of the Epic features we all talked about, they're $100,000 a year each right now in the current pricing. Now, we hope this changes soon, but when we talk about the message draft reply for providers, that's 6 cents a message. So you really need to be thinking about value proposition in a balanced approach, because before we really just focus on AI and governance, and you have to really find a balanced equation so that you have a fiscal responsibility to still operate effectively as a health system. And I think AI expense is something that's just, there's a lot to do there, and you really have to be thoughtful about how you line that up and set yourself up to have a balanced portfolio.
Thanks. Albert, last word. Where do we go from here?
Well, the warm-up thing does resonate, although growing up in Europe, baseball for me is like watching grass grow. So I will not continue the analogy on the baseball front. I will say this.
Go Padres.
I will say this. We're at a stage where we're like any emerging technology, right? We're going to see this kind of hockey stick shape curve evolution, right? That where we're going to see great things come. We're going to have some learning, right? All of our organizations, I'm sure, have work in use cases that turned out not to pan out, right? And I think we're at that stage where I would encourage you all to take some action, take some movement forward, right? It may not all pan out. Be thoughtful, right? Consider cost, consider risk, consider the ethics of it, but look for use cases and that you already have, and then try to see where your dollars can be best spent. But this is going to entail some failures too. And I guess my point here is don't be rash about it, be thoughtful, but don't be afraid of trying things. They may not pan out.
Thank you. Shane, final word.
Yeah, I'm reminded of a quote as I'm listening to the panelists today, and I don't know the attribution of it. It might actually be a Marvel-associated quote, but it's with great power comes great responsibility. And
Pretty sure that's Spider-Man, Shane.
That was Spider-Man.
so,
You didn't think that's where this was going, did you?
but I think actually the quote is, it really summarizes the conversation today. These advanced technologies that we're discussing possess great potential. I think what you've heard is that that needs to be applied in a very organized, structured manner. It requires engagement. It really comes back to the initial question, which is, it starts with first principles. If we're introducing a new technology into healthcare, it really cannot add more complexity. We have enough of that today. So we've got to protect against that. And that means that we have processes by which we evaluate, that we assess the risk of introducing bias, and we choose whether or not we can tolerate that introduction potentially of bias, that we have an ethical approach, that we're not overly trusting. This is really about human-computer symbiosis, right? And so there still needs to be a human in the loop. And this needs to be human-centered, and it needs to really focus on what's the improvement opportunity that can be realized. And I think those first principles become very important in terms of helping to advance this in a way that ultimately healthcare will be able to look back 10, 15 years from now and say, this was a very important moment in terms of how we're effectively utilizing technology and realizing that potential.
Yeah, well, with that, thank you so much to the four of you. I don't know, Demetrius, if you're coming up next, or are we headed to a break? No break. All right, sorry, no break.